You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. I want to thank all of you for joining us on this episode. Today, we'll be discussing hairy cell leukemia, from diagnosis and symptoms to approved and emerging therapies, as well as managing relapse disease, survivorship challenges, and strategies to support patients. We're delighted to be joined by Dr. Paul Hampel, who's an assistant professor of medicine in the Division of Hematology, Department of Medicine at the Mayo Clinic in Rochester, Minnesota. Paul, thanks for joining us.
Dr. Miller, so great to be here with you. Really looking forward to the discussion today.
I think as some of the listeners have heard, I've been in practice a long time. I remember this is early in my career. It was very exciting with hairy cell. I mean, truly, we were starting to cure this disease. This was before CML and other blood cancers. So I want to check in with you. Tell us, where has the field gone since some of those early advances?
The field has had an additional period of excitement, I'd say, over the last decade and a half or so, with the discovery of BRAF mutations in essentially all or vast majority of cases, and that leading to increased understanding of the disease and an additional therapeutic approach becoming available. But it is interesting how you bring this back into the historical perspective, because the time with which I've been seeing people with hairy cell has all been in this more kind of golden age. And
Yes.
The way that I learned about it when I went through training, the purine analogs had already been around, and so this was seen as one of the real successes. So it takes a bit of actually going back to find that historical perspective of how poor of outcomes could be when we didn't have the tools that we have now, or had beginning in the 80s or so with the purine analog. So I always appreciate that historic perspective, especially in disease like hairy cell leukemia.
So along those lines, I think you actually started to address it, but what do we know about the biology of hairy cell? Where is the defect or defects?
Hairy cell leukemia, in general, people will refer to this as a mature B-cell lymphoproliferative disorder, a post-germinal center type of mature B-cell. But the cell of origin and work into really understanding that, I was just at the Hairy Cell Leukemia Foundation meeting, attending virtually last month, I guess now we're in November, and hearing exciting work where people are still diving deep to truly understand some of that biology, despite knowing enough in certain areas about how the cell works and what it's susceptible to have the effective outcomes with therapies that we have. And as alluding to the BRAF mutation that's seen in essentially all cases of classic hairy cell leukemia, this RAF, MEK, ERK pathway activation that is so important to the survival of the hairy cell leukemia cells. I think maybe when you look at this preclinically and trying to understand the pathway, is this doing more to lead to proliferation of the cells or prevent the cells from dying, given this process is more of a chronic condition than a highly proliferative one in most cases? It's probably more of the survival, the resistance of death there, that this pathway then allows the hairy cells to achieve, and that can be so effectively targeted with agents.
In your clinic, your clinical day-to-day, how do patients present? What are the things that they first notice or their doctors notice? I'd love to hear more about that.
So I think that's going to depend. That might be a little bit different in my practice than your practice or others, because one, being at a tertiary referral center, and two, because one of the reasons that I'm interested in hairy cell leukemia, that I have this expertise, is because I came on staff and overlapped in my training with Dr. Tim Call, who was a senior expert clinician here who had built up a very large panel of patients with hairy cell leukemia. And so I've been fortunate to take the baton and keep carrying it. But what that means is I'm seeing patients who've already been through a number of lines of therapy, who were diagnosed long before I started practicing medicine. And now I'm trying to keep running that race with them. And so I'm always a little bit surprised, or can be surprised, or keep an open mind to the way that the disease may present differently later in the course, and especially as this is how patients present, but that's how patients presented, in the past when there was just purine analogs, or when there was just interferon, or there was just whatever. And now, as you actually have more novel therapies or new approaches, the disease may actually look differently later on down the line. I think probably what you're really asking here, the initial presentation, or how people kind of show up coming through the door most commonly. And I think it's due to the manifestations of the disease. So we'll say splenomegaly is a classic one. So symptomatic splenomegaly, patients come in with the abdominal fullness or early satiety manifestations of large spleen that certainly have seen people come in. And because these patients are typically diagnosed in middle age, in their 50s, certainly have patients who are in their 30s or 40s or younger. Not uncommonly, they're healthy and don't have other medical problems, and you don't have a whole bunch of blood work to look at. You don't have prior scans to look at. And so people can come in and have pretty remarkable splenomegaly even the first time you see them. So that's one way. The other way being the one that we perhaps fear the most, which is you're on the consult service for the hospital, or getting a call for a patient that is presenting with severe pancytopenia and are admitted with a severe or life-threatening infection. And those are the ones that probably stick out the most to me. The young person, say a man, for the sake of there being a kind of 4-to-1, I think, in male to female predominance with the disease, and guys are kind of notorious for sweeping things under the rug. So I think of patients where they had symptoms, been feeling unwell, sweep it under the rug, go to the ED or get treated for pneumonia, don't get better, come back. Now they're hospitalized and they're in the ICU, and counts are showing very low hemoglobin, platelets, neutrophils, and the important one that I think is kind of the tip off here, monocytopenia. That's a more unique cytopenia when it comes to hairy cell leukemia. So that's the more feared presentation, I would say. Additionally, then you have folks who have more just constitutional symptoms. Those are perhaps the most nuanced, because this is, I think, something that somewhat applies across the indolent lymphoma leukemia realm, where people find out they have a disease, they pull up the patient education, they see fatigue at the top of the list, and they say, okay, everything is solved. But if you don't have the associated anemia or splenomegaly or other disease burden, it can be more difficult to connect those dots, although acknowledging the cytokines that are coming from these hairy cells might be an additional unique angle there. But in short, constitutional symptoms, predominantly more fatigue and perhaps weight loss, less so of the fevers and night sweats that we call B symptoms, so to speak. And then I think the growing bucket here, certainly anecdotally, what I would say I see more is the incidental diagnosis, where maybe that used to be 1 in 10 or 1 in 5 or so. And I think increasingly seeing more patients who are diagnosed because they are having more routine blood work, perhaps, and someone spots a low blood count and gets a peripheral blood flow cytometry or morphology, and there you go. So I'd say that group is probably the one that's growing. The life-threatening infections, the one that I fear the most, and kind of mixed bag of the others of constitutional symptoms or cytopenias, splenomegaly.
I want to ask you about the cytokines from the perspective. I mean, it's always interested me, the pancytopenia. Is that from basically replacement of the bone marrow? Is that from cytokines? Is there suppression of normal hematopoiesis? Or is it physical?
Yeah, that's a great question. I think it's both. So certainly you can get a bone marrow core, really is where we're going to find all the disease, because as we all, I think, learned in medical school, the dry tap that you can get from an aspirate with hairy cell leukemia, but the core, you'll see the burden of disease in there, and it can be full. So there can be replacement of the marrow, but there is certainly an aspect of suppression, and the cytokine-induced suppression on the marrow and the myeloid precursors is certainly something that contributes to that more unique monocytopenia seen with hairy cell leukemia. And then different cytokines that are leading to the reticulin production and deposits in the bone marrow that gives you that dry tap as well. So I think it's multifactorial there. And then, of course, we all love multifactorial in medicine, just listing all of the possible things
Absolutely.
without ascribing this
Thank you.
particular percentage. But patients with very large spleens, I'm sure some sequestration, contributing there as well. But as far as what's going on in the marrow, I think it's actual disease burden, it's reticulin fibrosis, and it's cytokine-mediated suppression. So the answer to your question is yes.
All right, so let's talk about that patient you get called to see in the hospital who's pancytopenic, not infected, but they came in with, let's say, severe anemia. I'd like to focus on what's your workup, but even more so, what are your considerations when you start thinking about treatment?
So this somewhat gets to diagnosis, because people will say, do I need a marrow? And truth, I think probably a lot of the times the guidelines, I don't want to be contradictory here to things that my name's on or others, but that bone marrow is listed. But if you have a very classic circulating population with a classic hairy cell leukemia phenotype, and they are not needing therapy right at that moment, I don't think that everybody necessarily needs to go immediately to getting a bone marrow biopsy. I'd certainly get one before starting therapy generally to know what is that baseline as kind of reference point. But the marrow becomes more useful when somebody shows up like this with significant pancytopenia, and maybe they don't have much circulating disease, and it's just a really low counts across the board type of picture, and you can't get as reliable of an answer, and you are going to be starting therapy, and you really want to know that you are dealing with hairy cell leukemia, and the classic hairy cell leukemia rather than the variant. You're doing the marrow, you're confirming the diagnosis, and then when you're starting therapy, the little nuance you put there of infected or not infected, I think definitely matters. We are all going to be very worried and wringing our hands about jumping in with the purine analog, specifically cladribine, in somebody who is profoundly pancytopenic and has an active infection, especially. In patients who have significant pancytopenia, you can still jump in with cladribine, but acknowledging you're going to go through some nadir before things are ultimately improving. And so I think there's a little bit more nuance and art to it there, where you're saying, is there an easier way up? When there is an active infection, for sure, kind of not going that route. And that's where historically things like interferon were helpful, and then the reduced dose pentostatin. So instead of the 2 milligram per meter squared dosing, that had been shown to be more safe. And that's not something that I'm really doing in 2025 or over the last few years with the availability of vemurafenib, the BRAF inhibitor, as monotherapy that does not cause the T and B cell dysfunction that you get with the purine analogs. And you do see nice improvement in the counts even over that first 4-week window that can, one, get you through whatever trouble you're in right then, and two, allow time even before you'd consider making that a more aggressive regimen by adding an anti-CD20 antibody, administering immunizations, and allowing them a chance to take, so to speak, before anti-CD20 antibodies on board.
So just historically, if we go back to the purine analogs, and again, this patient who's, let's say, sick and infected, what are some of the special considerations for community oncologists like myself in terms of prophylaxis? You mentioned vaccines, you mentioned, of course, antibiotics, but what are we covering for viral, bacterial, et cetera?
So getting into some of the supportive cares will vary by the regimen. When we're talking about the purine analogs, these result in profound CD4 lymphopenia. And what we're covering for there is the infections associated with that. There's a little bit of debate on these, I think, but I'll tell you what my practice is, which is antiviral and pneumocystis coverage. And how I do that would be with acyclovir or valacyclovir for the antiviral, certainly HSV being one of the main things that'll pop up without that post-cladribine treatment. And then for pneumocystis, generally I'm using Bactrim here, but starting specifically, this is something that evolved over my time managing these folks, starting it not at the very beginning, not on day one, because you will get rash. Rash is mostly going to be a conversation piece with the BRAF inhibitors, but you do get rash with a cladribine-based approach occasionally. And if you're starting them simultaneously, it gets confusing. And I think there is some literature suggesting that the impact of the cladribine simultaneously with the kind of cytokines flaring of dying hairy cells, and the impact on the T cells can actually make the rash easier to come about from Bactrim. So I'll typically delay that by at least a week and then start Bactrim, and still favor that over, let's say, pentamidine or something else, simply because you are getting better coverage for other things, toxoplasma or otherwise, when your CD4 count is going to be below 200 for a little while. And generally, we'll continue that on for 6 months beyond the cladribine and check a CD4 count and make sure it's climbed above 200 before discontinuing the pneumocystis and the antiviral prophylaxis. And otherwise, beyond that, that's definitely a point of stressors for patients, because seeing a red flag in your EMR next to the CD4 count, if you keep checking it, it'll be there for quite a while. There's data with cladribine and pentostatin that you're looking at over 3 years. I think it was maybe somewhere in that 3 to 4 plus years before it climbs into the lower limit of normal.
Yes,
which isn't what we need. I want it above 200, and then we can turn down the dial on the concern. So I don't keep checking it actually after that. We would generally be assessing in 6 months after to turn off those.
Yeah. So if you were to survey your past year of patients presenting, what percentage are getting cladribine and what percentage are getting a more targeted therapy?
So in my practice, still, unless there is a reason that we're selecting for vemurafenib-based therapy, BRAF-based therapy, or otherwise in the first treatment, we discuss it, but generally I'm favoring the cladribine-based approach, and it's really more of a discussion of, are you getting single-agent cladribine or are we including rituximab with it? So there's an important study going on right now that is comparing first-line vemurafenib plus anti-CD20 versus cladribine-based therapies. We're probably quite a ways out from a efficacy readout there, maybe a tolerability and safety readout, which is also very important to our patients, will come certainly sooner as you just go through the therapy and you see it. But efficacy wise, I think they're both great approaches. I'm still using cladribine based treatment as first line.
Got it. So standard of care is cladribine, potentially cladribine plus Rituxan or an anti-CD20, or that's not standard now?
I'm willing to call that standard. It requires a little bit of discussion, like all things with this. I don't know if there's uniform consensus on it. We know that cladribine is on its own, as we kind of led off the show's episode with, is remarkably effective in this disease. It's quite condensed, whether you get the 7-day pump or you get the 5-day short infusions. In a week, you're done. You got to kind of make it through that month of nadir counts and keep recovering, but it's still quite condensed therapy that is going to result in a response in nearly every patient, not necessarily a complete response in everyone, but a response in nearly every patient. And when we're talking about median durations of response or median progression-free survival that is routinely reported at over a decade, that's remarkable. And so it's very effective. But there are patients that are diagnosed at a young age. When we're saying most patients are diagnosed in their 50s, again, I see a lot of patients with CLL as well, so 50 is very young for me. But if we quote somebody a number that sounds high in the realm of oncology in general, but they're in their 30s or their 40s, there's no number you can tell that person that's big enough. They've got their whole life ahead of them. They got so much miles that we need to cover, that when you're talking about, well, there's something that can make this more effective, that's where the addition of rituximab comes in. And so certainly for younger patients, and even we'll take age out of it a little bit and say, fit patients where they have a good amount of longevity ahead of them, I think that rituximab offers a reasonable added efficacy benefit without an undue burden of toxicity.
We'll say a relatively young 50-year-old, they're treated. 10 years later, they come back and they've relapsed. What then?
Yeah. So if they got cladribine alone the first time, then
yes,
for sure I'm using cladribine plus rituximab in the second line setting if they've had that nice initial response. I think the initial response with purine nucleoside analog therapy is really the best thing that we have to go by in predicting the future, so to speak. I say this because there has been work at looking at MRD in that setting. Certainly intuitively we think deeper response is going to be better. There's actually been so few relapses in some of the studies that have assessed this that it doesn't necessarily pan out, that you can't actually pick up progression events even if you have it. So I think there's that risk of actually getting into more anxiety where it's not something that we're necessarily using to guide therapy. That's certainly one of the ways it was studied, the rituximab and cladribine. Cladribine, the way that it was studied at MD Anderson with cladribine given, and about a month later, the rituximab, 8 doses beginning, or at the NIH study that gave some preclinical data suggesting maybe improved susceptibility of the hairy cells to cladribine in the setting of rituximab. So they were given at the same time, started both cycle 1, day 1, and continued. That's the concomitant. That study also had delayed, which was based on whether or not the patients achieved a UMRD with cladribine alone. And so it's not really a comparison of giving it at the same time or later, because all the patients who got it later were, by virtue of getting it at all, had selected out themselves as having disease that didn't respond as well. When I'm using the combination, I'm generally favoring the former approach, the way that it was studied at MD Anderson, simply because you don't get those overlapping infusion-related reactions with the cytokine releasing dying hairy cells and flare there. By waiting a month, kind of goes smoother. In my opinion, you get excellent results with any of them. But to the point of that approach, the same study did have patients who were receiving this cladribine and rituximab as their second purine analog therapy, and they essentially did as well as the patients who were getting it for their first, which is not what we had seen historically with cladribine and pentostatin. It works for a long time. When you get it again, still works pretty well, but you're going to get diminishing returns. That's true for so many malignancies. You get kind of diminishing returns in later lines of therapy until something changes the paradigm. And rituximab does that a bit, where you actually can get a longer PFS2 with cladribine and rituximab than you might have had with your PFS1 with cladribine.
Wow, which is great.
I think that's the approach in short. If somebody's had a durable remission with purine nucleoside analog therapy, then going back to the well and can repeat cladribine but with rituximab would be a great approach for that patient. If they've had a short remission, and how you define short kind of depends, certainly these under 2 year, but I'd say even under 5, you really got to go back and look, did I get this right? Do we have the right diagnosis? Is this variant hairy cell? Is this a different blood cancer altogether? I've had a patient that there's this little bit of cyclin D1 expressed with hairy cell leukemia. It's not from translocation 1114. It's again through the RAF-MEK-ERK pathway, I think, but not a translocation 1114, not the same as mantle cell lymphoma. But I've had a patient who this was kind of overlooked. I saw them, they're getting ready to go on, actually in both scenarios. I've seen this go both ways. One where someone came in diagnosed with mantle cell lymphoma, and someone who came in diagnosed with hairy cell leukemia, and it ended up being vice versa. So I guess the short version of this, if you have an underwhelming response to first line cladribine, you got to go back to the drawing board and make sure you're pointing at the right thing.
A question related to that: are there patients that are cured, who get a cycle of therapy and never have a problem again?
Yeah.
So they're functionally cured.
Yeah, functionally cured. Okay, good. I think this gets philosophical, Ken, because
yes, it does.
There's that scenario where if I treat you with something and you're in a long-term durable remission, you never get therapy again, doesn't impact your quality of life from a disease-specific manner, psychologically being another story, but is that enough? And I think it's especially relevant because we have a growing toolbox. How many things do you want to throw at the disease to achieve complete eradication, potentially at the expense of additional toxicity? We get additionally sensitive measures of assessing the disease. It was IHC, flow, now molecular testing with the identification of BRAF mutation or such. But even if you could get down to 1 in 100 or 1 times 10 to the minus 100, some infinitesimally small needle in the haystack, that patient hasn't had their disease eradicated or cured. And what does that mean? To your point, if you look at everybody, I think it's still more than half of patients who may not get an additional therapy, especially as patients get older. So then that first line therapy really does kick this down the road in an indefinite way. There was a study, I think, from Scripps, institutional experience, that looked at younger patients, in this case defined, I think, at age 40 or younger, where of course that number goes up, and it was, I want to say, maybe 2/3 or double the amount of patients that ultimately needed some therapy. A second line, the disease relapsed in a way that needed treatment. So still, even in that young group with fairly long follow-up, you're seeing patients who might get treated and not get treated again. So that gets into that more functional cure, because when you look at the plateauing of the curve, it doesn't really plateau with enough follow-up to say that the disease is gone and is never coming back if you followed people forever. It will for some, but are you eradicating the disease? I think the answer there is no. The most aggressive approach, where lots of diseases we say, okay, the only cure is an allo transplant, but it comes with so much morbidity and mortality and this and that. Even in, I think, the EBMT data for allo in hairy cell leukemia, that PFS curve didn't plateau, and there was pretty substantial early treatment-related mortality. So true eradication of the disease, probably not, but functional cure, and one that probably warrants us not trying to be too over-aggressive for the majority of patients, yes.
What are some of the things you're excited about, new emerging therapies, and also clinical trials?
The success that we've had in hairy cell leukemia has led to people who may not see as much of the disease or just know of the success of purine analog saying that this problem is solved. And I hope one of the messages imparted here is for patients, especially diagnosed earlier, they are going to need multiple lines of therapy. And even for patients diagnosed later, I think there should be that movement, that drive to make things still either more effective and or better tolerated, and perhaps continuing to emphasize on the latter. So certainly when I'm seeing patients that have gotten multiple lines of therapy, I mean, I think I have a patient where the list is in double digits of prior lines of therapy. You do start to run out of things. The purine analog doesn't work anymore. They've received multiple lines of BRAF inhibitor based therapy, and you still are looking for additional options. So I think we still need ongoing innovation at large. And for that subgroup of patients that either are diagnosed young and have multiple relapses, or maybe about the 10% or less of cases that have something unique about their disease where it is more aggressive. I think probably classically we'll think of these as folks who maybe lack the BRAF mutation or have something that looks different about the disease, not even variant per se, just a classic hairy cell that has something different about it. But there are some that really read the textbook. They've got classic immunophenotype, they've got BRAF mutation, V600E, and then they don't read the textbook. Then they don't follow the papers, and the disease is more aggressive. So I think there's still room for innovation here. I think really fine-tuning approaches for patients for the amount of therapy. Maybe MRD does ultimately lead to some tailoring of therapy for patients. I think the vemurafenib story, we've circled back to this a few times, but there's still work to be done there. The Italians appear more robust than us in their ability to handle 960 milligrams twice daily. From a side effect profile perspective, I think here the experience has been that essentially all patients end up getting rash, and maybe 2/3 of them getting grade 3 rash that ultimately leads to dose reduction. On the other hand, some of the data showing that using lower doses, certainly below the 480 twice a day dosing, might result in less efficacy. So I think there's work to be done in fine tuning exactly where the dosing and the combination approach with anti-CD20, for example, those are pieces of active research for an already kind of home run, clear, great advance, but one that can be fine-tuned. BTK inhibitors, of course, have had their moment across B-cell lymphoproliferative diseases, and that includes some in hairy cell leukemia. The initial work with ibrutinib from Dr. Kerry Rogers at Ohio State, I think, got a little bit overlooked because the response rate was underwhelming. It didn't hit its primary endpoint for overall response rate by a few months in. I can't remember the exact time. But actually the response is deepened over time, and it does a very good job of actually controlling the disease. And so I think that was classic hairy cell, but there was also patients with hairy cell leukemia variant in there, and especially for that latter group are an effective option. Some data with zanubrutinib, kind of second generation covalent BTK inhibitor. So those are good things to keep that I would reserve certainly beyond the purine analogs and the BRAF inhibiting approaches, but BTK inhibitor there.
Any role for venetoclax or that class?
Yeah, of course. So venetoclax, I think definitely there may be an emerging role there. There was a correspondence and maybe a case report with 5 or so patients published in the New England Journal from Dr. Tiachi with venetoclax in patients with classic hairy cell leukemia that I think all of them had received purine analog and vemurafenib. Encouragingly, there were definitely responses seen there. Again, responses that I think looked better when given in combination with an anti-CD20. And there's at least one case out there of combination, again, kind of pulling from the CLL and mantle cell world of combination BTKI and VEN. So there's definitely proof of concept, both preclinically and now clinically, that there is some legs to targeting anti-apoptotic proteins BCL2 in hairy cell leukemia. Encouragingly, I don't think they saw tumor lysis syndrome in any of the cases reported yet. There will likely be some differences in that timeline to count recovery and perhaps especially neutropenia when we're talking about targeted agents. And if this were to ultimately kind of move up or be looked at earlier, I don't know if I see that, but certainly for patients later on, it's an encouraging option. And there is a trial running, to your point. I believe it's at the University of Miami. I can't remember what other sites, but there is a trial of venetoclax in hairy cell leukemia. The other things being added to the box here would be other ways of targeting that RAF-MEK-ERK pathway. So other BRAF inhibitors and BRAF inhibitors in combination with MEK inhibition. So kind of borrowing from other diseases or BRAF mutated colorectal cancer approaches or otherwise, that type of double hitting, because that's what you're seeing in the resistance to BRAF inhibition monotherapy. You see ongoing phosphorylated ERK, some bypassing of that BRAF activation there to still get the pathway going, not additional mutations in BRAF. And I guess going back to BTK, you don't see mutations in BTK like you do with CLL, these C481S and so forth. So there's definitely some interesting pieces there.
So I have to say, we've sort of been teasing our listeners today. So now I've got to ask you, what is the hairy cell variant?
Yeah, I might have to come back for another show to answer that, Ken. But in short, this was kept in one classification system, the ICC in 22, but actually abandoned in WHO 5 and lumped in with other diseases. So it's a bit of a controversial topic, but there's features like the hairy cell projections that are still there, but certainly differences in the immunophenotype, the lack of BRAF mutation, the presentation usually in older patients and with higher white counts, and most importantly, someone that is going to not derive that same benefit from monotherapy with cladribine or purine analog. So important to distinguish whatever name you give it to guide your therapy for those patients.
So I want to ask you also about the broad topic of survivorship. There's 18 million cancer survivors. We look at the great success in hairy cell and CML, and you've got a large number of long-term cancer survivors you're taking care of. Tell us about one, if you would, and just in general, what are some of the issues that they face?
Yeah, that's a great question because I think survivorship really comes into focus and central once you get through the therapy, because we expect most patients to do well for a long time. And there's that intensiveness of the diagnosis, especially presenting in somebody who needs therapy right away, and then the intensiveness of going through that initial therapy. And then it's kind of a what's next. And we talked a little bit about the immediate survivorship from an infection prevention standpoint. But beyond that, there's quite a bit that still comes along with survivorship. So I think of patients that I've cared for that really struggle with that transition, with thinking about, okay, I have this diagnosis. I've been told, say I'm diagnosed at age 50. There's a good chance I'm going to still be dealing with this again later and feel like that's kind of hanging over them. And so getting out of this re-entrance into a surveillance and watch and wait and more into a watch and live, and doing so in a way that you're still covering the bases, you're still keeping tabs on these folks and walking that path with them, but it's not dominating every thought. That is probably the biggest barrier that I see for a lot of people going beyond it, because the infection risks, once the counts recover and once you get away from the immediate therapy, are going to go down. It's not something that people need to live in constant fear of the next life-threatening infection. We generally will still follow folks. I'll see them on a routine basis that kind of spreads out, especially when you've had that nice response, so that we're not overburdening them with visits, but still seeing them at least once a year. And part of that, as it gets into survivorship, is talking with individuals about age-appropriate cancer screenings. This is another area that probably gets a little bit of mixed data, both from well-conducted studies that come up with a little bit of conflicting results on what exactly the increased risk of other cancers is. Some really showing no increase in that standardized incidence ratio. And I think a SEER study that did show, at least for maybe Hodgkin, non-Hodgkin, and thyroid cancer, some increased risk. I'm not sending these folks for whole body MRIs or the pan cancer methylation blood tests or anything. yet. We don't have any data for that, but at least added emphasis on the age-appropriate cancer screenings. And then a way that I actually put this that I think is helpful in general for healthy lifestyle and mentally is that, hey, I expect you to be with us for a long time. I expect you to live for a long time. So you can't leave my office here today and say, woe is me, I've got a leukemia. The last word always hanging the heaviest on folks. And so it doesn't matter if I have a bowl of ice cream tonight and every night for dinner, or stop doing that run or whatever else. I say, no, you do have to do those things, because you do have to worry about all the other things that are major causes of morbidity and mortality, because we expect you to be with us for a long time. So there is that still ongoing, if you almost say, wearing your PCP hat of saying, yeah, you do have to continue to maintain the diet and exercise and healthy lifestyle measures, in addition to being cognizant of a potential increased risk for other cancers and doing age-appropriate cancer screenings, certainly stacking the odds in our favor where we can with things like immunizations to prevent infectious risk. And then a lot of it is saying the reassurance, hey, I'm going to walk this path with you. We hope this doesn't come back for a long time. When it does, if and when it does, we've got good options. World Series just ended. We've got arms ready in the bullpen that are ready to come in and take over the game and keep you going. So I think a lot of that is the relationship that you have the privilege of building with people in the setting of diseases that are more chronic in nature.
So I have to say, so well said. I really appreciate it. I think this is the first time I've heard the term watch and live instead of watch and wait. So thank you.
I got to say, I got to give credit. I stole that from a patient.
Wonderful.
I was someone who used to say watch and wait, and I knew that patients would call this watch and worry. You know, it applies to CLL probably most, but follicular lymphoma or hairy cell when not needing treatment. And then I kind of shifted into active surveillance. You know, we're not just sitting on our hands waiting for the other shoe to drop. We're watching you and doing this. And then I had a patient that said, no, doc, you do the watching, I'm going to do the living. And so I've stolen that from them, and I'm giving credit here.
Good for them, and thank you. I really appreciate it. And finally, I wanted to ask you about resources. What are some good resources for patients with hairy cell?
Yeah, definitely. And on topic with this conversation, the Leukemia Lymphoma Society, now Blood Cancer United, is an excellent resource that I'm putting in to direct patients to in all of my notes, essentially. And part of that, the Clinical Trial Support Center, Nurse Navigators, that is an awesome resource. We talked about trials earlier, didn't have a chance to cover all of them. There's certainly more going on in here, and that's an incredible resource. And I think a partner with BCU or LLS is the Hairy Cell Leukemia Foundation. They share, I think, some research initiatives and grant funding mechanisms, but certainly a partnership. It's a cool thing about hairy cell leukemia, I'll just say briefly, is that this is a relatively uncommon disease, right? And so the importance of partnering, of collaboration across everywhere, across academia and community practice, where if there's only 1,000 cases a year in the US, you're probably not going to see so many of these. We need to help each other out, but then across academia, we can't come up with a billion different questions and think we're going to answer all of them with a small number of people out there. And you do see that people are passionate about still advancing the outcomes, advancing things for patients with hairy cell leukemia, and they're collaborative in it. And that gets me as excited as anything about working in this field.
Wow, very nice. So again, this is Dr. Ken Miller. I want to thank all of you for listening to this really terrific episode. And I think we really covered a lot of history and a lot of science. So it's really been wonderful. I want to particularly thank Dr. Paul Hampel, who is an assistant professor of medicine in the Division of Hematology at the Mayo Clinic. Paul, thanks so much for being with us.
Absolutely, my privilege.
And for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit bloodcancerunited.org/CE. And for questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955 4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and other support resources that are available in English and Spanish. Blood Cancer United also provides other resources for patients, survivors, and their families that can be found at bloodcancerunited.org/support. I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.